All right, so ED management of acute COPD. He taught me in med school. It is awesome. Okay, ED management of acute COPD exacerbation. That is me. Special thanks to our small talk team. This is going to be very quick, about 10 minutes review of presentation management of acute COPD exacerbation, including a little bit on ventilation, some on medications, including bronchodilators, antibiotics, and steroids. I tend to be quite verbose, so I got it down to about 12 and a half minutes total. So first off, our patient presentation. So we have a 57-year-old female, history of prediabetes, no pulmonary history, but she does smoke 2 packs per day for 30 years. Crosby called 911 due to 7 days of shortness of breath and productive cough. So review of systems, no chest pain, lower extremity edema or asymmetry, no fever, travels, or known sick contacts. On arrival, her vitals are this. Her exam is that she's not speaking in full sentence. She's got some accessory muscle uses. She's got wheezing and poor air movement. So at this point, we are working this patient up. We're considering which pathway are we going to go down. Our differential is going to include such things as reactive airway disease, aspiration, pneumonia, pneumothorax, allergies, maybe anaphylaxis, but not super likely. Who's concerned about a PE for this person? Right? A little bit, a little concerned. You should be concerned, right? She's got some things concerning. She's got a little tachycardic, she's tachypnic, her saturation is bad, 81%. Can we perk her out? Not really, right? She gets it for age, heart rate, and oxygen. What's her Wells score? It's 1.5 just for heart rate. So it's a pretty low Wells score. So maybe we consider a D-dimer before a CTA for her. But we should be concerned about PE. There was a 2014 study that showed that the incidence of PE in acute COPD exacerbations is about 29%, with obesity and lower extremity asymmetry being independent predictors. Also predictive of PE was immobility, systemic inflammation, and polycythemia. Okay, so consider PE is the major takeaway there. So we're working her up. We're going to do our classic IV O2 monitor. We're also going to get an EKG. 20% of patients with COPD do have coexisting cardiovascular comorbidities. You tend to see tachyarrhythmias, and you can also see some right ventricular hypertrophy leading to some right axis deviation. We're going to get a chest X-ray, which this is your classic COPD chest X-ray. We're looking for consolidations. Is this a pneumonia? The typical radiographic findings, as we are aware, is going to be overinflation of the lungs, flattening of the hemidiaphragms, increased retrosternal airspace, bulle. And then if we end up getting a CT, you can see what's called a saber sheath trachea, which is just lateral compression of the trachea. It looks like you could fit a saber in. Also, we're going to get, for labs, we're going to get a CBC. We're going to expect to see some polycythemia. Look for leukocytosis and bandemia to indicate some sort of other infection. We're also going to get our ABG or VBG. In the ED, we're probably going to get a VBG unless we're in CCT and we're getting this patient ready for the ICU, in which case we might get an ABG. What might we expect our blood gas to show in acute versus chronic COPD? Think about your acid-base status. I'm not going to wait for people to talk. I'm just going to go ahead. I don't have that much time. So if the pH is normal and the PCO2 is elevated, then that's going to be your chronic CO2 retention. If bicarb is also elevated, then we know that it is compensated respiratory acidosis, this ergo chronic. Right? Having prior labs for our patients and a baseline bicarbs is beneficial, but we don't always have that to know where they're at, okay? What else? Considering, yes, ABG, I mentioned, troponin, BMP, sputum gram staining culture, respiratory viral panel, sure, dimer, we already mentioned that briefly. Okay, next, I mentioned O2 briefly. I'm just going to quickly go through non-invasive. Dr. Ferrante just said all this for me, great. But the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, They recommend non-invasive ventilation for if the patient is in respiratory acidosis and if they're having severe dyspnea. The whole idea there is to minimize the intrinsic PEEP, minimize the work of breathing, and to minimize the metabolic demand. You could read the slide yourself. The goal FiO2, as we're ventilating them, is going to be between 88 and 92. And so the idea here is to prevent intubation because like Dr. Faranje mentioned, it is dangerous to intubate these patients, right? You really got to worry about the barotrauma, about the breath stacking. So if we can't avoid that, we'd like to avoid that. Now, in my reading, it seemed that if you are having to intubate the patient, then consider using ketamine due to maintaining respiratory drive and to its antimuscarinic effects. As Dr. Franche mentioned, when we're breath stacking, we can cause barotrauma, which can lead to hemodynamic collapse due to the increased intrathoracic pressure and decreased preload, okay? Goal respiratory rate for these patients should be between 8 to 12 with a tidal volume of about 6 cc's per kg ideal body weight. We also, if we're having them intubated, let's pay attention to our IE ratio, our inspiratory-expiratory ratio. These patients take some more time to expire. And if you start to get worried about them breath stacking, you can, like was mentioned, you can manually compress the chest. Just take the tube off the ET tube and press on their chest. I did it a couple weeks ago with in the ED here. Okay, so a 2005 study actually did show that at 1 hour after non-invasive ventilation, if the patient has a pH under 7.35 and a respiratory rate above 20, then that is predictive of need for intubation. So just keep in mind, an hour afterwards, reassess your patient, give them the trial of non-invasive, and see if they're improving. Okay. So other management, bronchodilators, we always use duonebs, albuterol, and ipratropium. You want to start them ASAP. A lot of times your nurses are already going to have them started. What else? So that's a beta agonist and an anticholinergic. And you could repeat those doses as needed. We typically will repeat albuterol, less so the ipratropium. Steroids. So we talked about the reduced trial with Dr. Faranje. Basically, that just showed that 5 days PO is not inferior to 14 days. Okay. Gold recommendations is oral prednisone, 40 mg a day for 5 days. Discuss that. Just as an example, I put the IV therapeutic equivalence doses. Methylprednisolone, apparently 32 milligrams is equal to oral pred of 40. We never give 32 milligrams of that. We also never give 6 milligrams of dexamethasone. Our doses in the ED tend to be 125 and then 10, 12, something of that nature. But just as an example, it doesn't take a whole lot of steroids to be beneficial. Magnesium, no recommendation for magnesium. Methylxanthines, who wants to talk about that? Not me. Moving on. All right. Antibiotic use in COPD exacerbations. Like we discussed, Dr. Franche mentioned the inflammatory marker, the ESR, CRP. There are studies that, like you mentioned, are showing that these can guide antibiotic use. Current gold recommendations are based on prescribed antibiotics based on symptoms, worsening dyspnea, increased sputum volume, and sputum purulence. Okay. The strongest evidence for antibiotics comes from ICU and ventilated patients. What else I want to mention? Okay, so a 2013 chest study of about 54,000 patients did show that the addition of antibiotics demonstrates reduced in-hospital mortality and 30-day readmission when given with steroids. And then the most recent data I found was this 2021 best practice advice in the journal, the Annals of Internal Medicine. They say to limit antibiotics to 5 days. They give 3 choices for antibiotics. They say an aminopenicillin with clavulanic acid, a macrolide, or a tetracycline. There's no difference in clinical outcomes between groups that took 5 days of antibiotics and groups that took 8+ days. And then also a sub-analysis found no difference in antibiotics class. So you could use any of those 3 classes, all right? And then these are the recommended antibiotics. So doxycycline 100, Zithro 500, and then so that's a Z-Pack, right? And then if they're inpatient, the recommendations are Augmentin or Levo, PO or IV. For the moxifloxacin and vancomycin or linezolid, they didn't have diagnosis. They literally said, ask your pharmacist. So Francesca across the street. All right. Uh, and then what is the dispo for this patient? So the American Thoracic Society, the European Respiratory Society, and the Gold Society admission guidelines essentially say this you should consider admission if the patient has severe, well, you guys can read these, okay? New physical signs would be like cyanosis, peripheral edema, altered mental state, and I'll say down to insufficient home support. With our patient population, you really want to consider like, is this person going to be safe when they go home, right? We have a lot of patients that end up coming back a couple days later. Is someone going to be home to monitor them and to make sure that they're actually improving? Or are they going to go home and then like get short of breath again and then just die at home in their bed because they just were at the hospital, right? So think about that. So then for ICU, this is the gold criteria. Consider ICU admission if there's severe dyspnea that does not respond to ED interventions, if there's change in mental status, worsening or worsening hypoxemia and acidemia despite oxygen and non-invasive ventilation, that is going to be a arterial PaO2 under 40 and a pH under 7.25. If they're intubated, obviously they're going to the ICU. Also, hemodynamic instability requiring vasopressor. The asterisk on that is that remember for hemodynamic instability, if they're intubated and the vent settings are inappropriate, they could be breath stacking and that could be contributing to their hemodynamic instability. Manually decompress the chest. Okay. So, and then these are our Kings County observations versus admission criteria. They're safe for obs if they have a known history, if they're improving in the ED and their chest x-ray is clear. On the other hand, we have some exclusion criteria, which does include non-invasive positive pressure ventilation. If they have to be on BiPAP, they can't go to obs. And if you expect them to stay for a long time, if there's other things going on. All right, discharge considerations. So if they are improving, if they can use their inhalers right, if they have their inhalers, right? If they have that home support in a primary care, okay, you're giving them steroids, you're giving them antibiotics as indicated. Smoking cessation. I know we don't really talk too much about it, but really consider it in your patients with COPD. A lot of these people just keep smoking because it's really difficult to quit. Consider varenicline. It doesn't work immediately. They could still smoke for the first week on varenicline. Also, varenicline makes you very, very nauseous. And then there are several vaccinations that they should stay up to date with. Okay. These are my references. Now we can move on to questions. Pretty sweet and simple, right? Sure.